First of all, we are going to start with the presentation of Professor Azadmanesh from Pasteur Institute, and it will take about 40 minutes.
It's my pleasure to be here today to share some of our experience in the case of establishing the network for COVID-19 testing in Iran, which might be also helpful for other countries. I'm Kayhan Azadmanesh from Pasteur Institute of Iran. So I would like to give you some of our experience with this regard, just an introduction to Iran, a brief history of COVID-19 in Iran, how we started setting up the molecular test, then how we established a network in Iran, and some of our experience in how we evaluate new kits, and a few slides on role of serological tests, and also finally the challenges that we have with this regard in Iran. So next slide, please. Well, just to give you an overview of what we're talking about, this is Iran. This is the map of Iran. This is the rather big country, 1.6 million square kilometers in the area, and with a population of almost 83 million people. And our capital is here, Tehran, and we have 31 provinces, and also we have a very diverse climate in Iran. Right now, when I'm talking here in Tehran, close to Tehran, we have snow in mountains northern to Tehran, while the temperature in Bandar Abbas is something around 40 or above 40, and in Ahvaz it is close to 50 degrees centigrade. And next, please. Okay. We have a unique system here in Iran. I think it's somehow unique with regards to, with regard to how we manage our health system. We have a ministry which is called Ministry of Health and Medical Education. It means that both medical education and related educations are under this umbrella, and also the health services and hospitals. So we train people within the field, within the hospitals, and within all the country. So each university, each medical university is responsible for health and well-being of people under its coverage. So it's somehow it's not really centralized system, and we provide the services in different countries, in different cities with different universities. We have 31 provinces and 65 universities right now in Iran. And this is what I'm going to talk about. We found our first two cases, in fact, on February 19th, 2020. And then you see that we had a lag here with a very small capacity of testing. Within 10 days, we increased this capacity to test over a few thousands. And then we had a peak at almost early March, mid-March, with up to 3,500 cases per day. And now we are probably in a second peak. So right now, the number of confirmed cases are over 150,000. And we have so far tested more than 900,000 people in the country during these 3 months. This is just an overview of how we expanded this network with the different techniques that we use. First, we started with a corona PCR, RT-PCR, and in January 25. And at that time, the capacity all around the country was only 10 tests per day. And only one lab was able to do this test. Then we switched to another RT-PCR, Nasal PCR a few days later. And then on February 9th, another lab came to do the testing. So we had 2 labs at that time. And just before February 19th, we had 4 labs which were capable of doing the test with a total capacity of something like 200 tests per day. And by mid-May, this capacity was increased to 20,000 tests per day. And right now, we have more than 150 labs in the country actively test. and more than 200 labs are ready to do the tests. Some of them are within the Ministry of Health and Medical Education. Some of them are affiliated to other organizations, governmental organizations, and most of them are, and many of them are private or NGOs. So there are two types of challenges that I'm going to a little bit touch them in this short presentation. One is how we did the test, and the second one is how we expanded the testing in the country. So for this second approach, there are very good documents, literature available in the literature. For example, this is from Association of Public Health Laboratories. This is from WHO, from Afro region, and how to strengthen the laboratory system. And most interesting to us was this one, Strategic Framework for Strengthening Health Laboratory Services, which is delivered through MRO, the WHO region. And it was, we mostly followed the instructions and guidelines of this document. You may know that there are different types of tests with different goals. Some tests look for the evidence of the virus, for the virus itself, for traces of the virus, either by checking the nucleic acid of the virus or proteins of the virus. Some others check or look for the immune response of the body by detecting different antibodies. And so both of them are now in use, and I will describe a little bit of each one. So in the beginning, early or mid-January, the guideline, the WHO released a guideline in collaboration with the Charité Berlin Hospital, and they introduced some primers and probes for doing the molecular tests. But even before that, it was a tradition for coronaviruses that we had to detect two sequences in the genome for doing real-time PCR, or alternatively, we could amplify one region and do the confirmation by sequencing. Early in February and late January, we had no primers and probes for real-time PCR, so we had to stick to this second approach. So a few days later, WHO released the second version of this document, and this was the suggestion of WHO at that time: do a screening test with E gene, PCR for E gene here, and then a confirmation by RDRP gene here. And so we ordered the primers based on this instruction, and we didn't receive it before maybe not earlier than 3 weeks. So we had to rely on other sources that we had. So we went back to our warehouse and looked for what we have. In 2012 and 2013, you may know that MERS-CoV emerged in this region, in the Middle East. So at that time, we had ordered and prepared some reagents to detect MERS-CoV in our country. At that time, one of our colleagues suggested that this might not be the last coronavirus, so it's better to have something that we can detect all the coronaviruses. So we ordered, based on the paper published in 2005, we ordered a series of primers, a pan-corona set, and you can see here it detects, it binds to most of the coronaviruses known at that time, and it has 43 base pairs, both primers, with 15 degenerate bases. So it's very complicated. It's not very specific, but it's very sensitive. So we asked our colleagues to check if these primers can detect the newly emerged coronavirus, which by that time the sequence was available. And they tested it, and it was okay. And I also asked them if, what if we sequenced the PCR product? It was 250 base pair, and we checked it with phylogenetic analysis and noticed that it can differentiate between different coronaviruses. So it was okay. In addition to this, we had a plasmid, a control plasmid with a synthetic sequence, which if upon amplification with this primer set, we would get a band of 130 base pair on this control plasmid, while on the actual virus, we have to get something like 250 base pairs. So the size difference was helpful to identify if a positive test is due to contamination with the plasmid or it is really the virus. So we started this as soon as almost January 25. And then in a few days, we switched to another set of pan-coronaviruses which were available in the country. We could synthesize them. This was again from a paper published in 2011, and it was for avian coronaviruses. This was again a pan-corona set which with again a lot of degenerate bases. We switched the degenerate bases to be in accordance with the newly found the Wuhan strain. And the PCR product was 60 almost base pair, 600 base pair with the first round and 440 base pair in the second round. So we had a larger fragment. We could do the sequencing more easily and we could identify it much better. And we set up a test with these new primers. We tested it on 2 other strains of virus that we had at that time, OC43 and E2293. And it worked. We made the PCR setting a little bit more relaxed, so we could amplify on them. And the idea was that if we get a positive result, if we get a band, we could sequence it first, and also we can increase the temperature to have more specific PCR reaction and to more selectively amplify only the Wuhan strain. And in a few days, we received the real-time PCR primers and pros, very limited number, only something like the one batch was 400 tests and the other one was almost 200 tests, so it was not so big. And we made a workshop with our colleagues in 2 other universities, 2 other labs. We set up our protocol, and this was the protocol that we set up based on real-time PCR and also based on confirmatory by RT-PCR, nested PCR, and electrophoresis, and then sequencing. And this was all before finding the first cases. So this was more, this approach was very conservative to make sure that we have not identified false, something else. But we really couldn't do this for a long time because just a few days later, our first cases were found. And then when we sequenced them, shall I go on? Okay. So overnight we sequenced that fragment, that almost 550 base pair fragment, and we found that it is 100% match with the known Wuhan strains. So by February 19, in the afternoon, we were sure that we have the disease in the country. On the same day, we started doing the tests on samples from other cities. The first 2 cases were from Qom in the center of Iran. But by the afternoon, again, we realized that it is not limited, it is not contained in Qom. So we have other patients from other cities, including Tehran. So we didn't think that putting Qom in quarantine had any benefit at that time. So this was the way that we did the PCR. We set up PCR before having the conventional or before having the commercial or available usual test. The second challenge was to expand capacity of testing from 200 tests at this time to something like 10,000 tests or 12,000 tests here, and now more than 20,000 tests. Again, going back to this document, these are the main strategic goals which are advised by this document. So six main strategic goals, and there are a lot of sub-strategic goals. I think that's a term in the document, and you can see them. First of all is the strengthening leadership and governance of the national laboratory system. Then strengthen the organization and management of the national laboratory system towards quality. This is very important. Then human resources is very important, and then to make sure that labs are safe, promote effective laboratory referral networking, having a network within the country, and then providing evidence-based decision or making this evidence-based decision in the country. So this is something that labs should do. And this document is not a step-by-step document, so you cannot follow it from the first, from the cover to cover. But you must pick up the concept and use the concepts. So, starting with the first goal, on the second day of finding out that we have this outbreak in the country, we established a national network, a national committee for the lab. And this was a high-level committee. It was governed by Pasteur Institute of Iran. Then we have representatives, in fact, directors of Department of Reference Health Laboratories, Department of Control Reference Laboratories of Food and Drug Organization, and then representatives from the Deputy of Health of the Ministry of Health. And we have a special organization within the Ministry of Health who is responsible for procurements and purchasing material from abroad. So we have all people in one room, and then we started to making the decision. And this committee has its meetings every week, or sometime in the beginning twice or thrice a week. Now a little bit less, maybe once a week. And we make the top decisions here. These four goals are somehow related to each other. So I'll just tell you the steps that we took in this process, so you can assign which goal is related to which step. So fortunately, we had a good human resources in the country. Many things related to this, in fact. And we had already a system, a network of laboratories for influenza and also for HIV within the at least 13 or now 17 universities in the country. And usually these influenza labs are responsible for collecting samples from the country, from the universities, from the provinces, and doing the tests, sending the samples to Tehran to the National Influenza Reference Center, which is in Tehran University. So we had them. They were familiar with respiratory diseases, so it's not a big deal for them. So they could be easily switched, they can easily switch their focus. The second strong point of our system was that we have a very good system for sending, for transporting of samples within the country. You may know that for the last, I think, 4 or 5 years, every year there is a big march in Arbaeen in Iraq with tens of millions of people attending in it. And many from Iran, some from Pakistan coming to Iran, some pilgrims come from Pakistan and then go to Iraq. So usually before that event, we have this practice before it. We ask the university to prepare samples, unknown samples, with the guidelines, and then send it to Tehran within 48 hours. So they were ready for that. We didn't need to do extra job in that regard. Then we sent 3 questionnaires to the universities, to the labs, asking if they have the capacity. They have the capacity of quality and training of personnel, if they have the biosafety and biosecurity measures in place, and if they have the laboratory facility available, suitable for this practice. If yes, then we asked them, we asked some representative of them to come to Tehran to have a brief, short briefing in Pasteur Institute. We just showed them how we work, or what is the process, the procedure, and what is the biosafety concern with this new virus. And they knew most of other things, so they went back. And when they came to Tehran, we gave them, each of labs, only 100 tests, just to go back to the lab, to their own lab, run the tests, run the controls, and see if they can run them properly. Then we asked them to send back the results to us. And also, if it was okay, we let them do 3 rounds of clinical samples. We asked them to send the results again back to Pasteur Institute. We analyzed them sometime in parallel with them, the same sequence, the same result, the same run on the computer, and then if everything was okay, we went to next step. And for this interpretation, these factors were important for us. If the CT of the control sample was similar to what we get in Tehran, if the shape of the graphs are okay, and how they interpret the results, especially when there is some discrepancy between different tests. For some of them, we asked them to send us also some samples to be retested in our institute. And after that, if they pass all of these steps, health reference laboratories granted them the permission to run the test by their own. And this was the way that we did it for almost 30 labs, 30 universities. And after that, we asked these major universities to do the same practice for the smaller ones. So we asked them to do that, but finally, again, the analysis in parallel and the granting the permission was centralized in Tehran, in Pasteur Institute and Department of Health Laboratory Service, Health Reference Laboratories. One big problem, which is still a problem, and I will mention it again in my last slides, is how to collect the data from the system. So you have a big network, but it's very difficult to handle so many cases. Just to give you an example, we had some web-based systems for collecting the results of or data of, for example, CCHF in the past. But the total number of CCHF cases in the country in 1 year has never been more than 800 cases. So you cannot compare it with 900,000 cases. And it could not work well with that. So right now we have 2 data collection systems, this is also a weakness of us because we cannot easily manage data in one system. We cannot handle it. And when we had more samples, more positive and negative samples, we prepared a panel of samples with different cities. We pulled some samples. We prepared a panel of high CT, low CT, and middle CT samples, and some negative samples, and prepared a panel, and we started sending them to the labs. And we have a questionnaire for that. We asked them to run the test, fill in the forms, and then send us their own interpretation. And right now, more than 200, I think 212 right now, labs have been enrolled in this system, and more than 150 are actively recruiting or getting the cases, getting the samples from the universities and run the tests. And in addition to that, we established a WhatsApp group to make communications more direct between them. And this was an advantage for us because they can easily now share their experience, their problems with each other, and seek for guidance from each other, seek peer reviews, things like this. And now this is really a network because we have both vertical connections between us in the Pasteur Institute and in Tehran and other labs in the periphery, and also among the labs in the periphery. So when they have some problem, they share their problems with each other and they share their solutions. And that's very good. And sometimes even they share the sample to cross-check with each other. So this is what we expect from a network. So this was how we established this network. Then some specific problems with this happened. One is we did not have enough kits. In early February and March, it is here. In February and March, there was no IVD tests in the market. All the kits available, most of them from Chinese sources, were RUO. So we had to evaluate them in Iran. And then these kits had multiple targets. So we had to choose which target we want to test based on the WHO guidelines and some other experience that I will mention later on. Then we received the first big batch of tests from WHO from Tib Molbiol. And it was a set of primer and probe. So this was our gold standard in the beginning. We compared all of the kits with this test. And then we gave them some certificates. Some were not acceptable if they did not pass the quality control, if they did not pass could not identify the positive and negative samples within a limited set of samples. We used an emergency use authorization plan. This was like what CDC in the United States used. They suggested 60 samples. Sometimes we use less samples. And anyway, if they passed the panel, we gave them the acceptable mark. If they were acceptable, and they also matched with our requirements. For example, if they could identify multiple targets in one tube, so they were multiplexed. They had their internal control, preferentially internal control from the human genome or RNA to make sure that the sample has been taken correctly. And if they had good performance, and finally, if they had a reasonable price. So we could afford it to expand it within the network. So in this case, we suggested to buy them also. And then we deliver these kits to all the labs in the country. This is still what we are doing, but we are going to change it because there are other organizations, there are bodies in the Ministry of Health which are more related to this job. So we want to go back to our research and development. Just to give you an interesting example of what we did for promote rational and evidence-based use of laboratory services, I want to mention this. Again, going back to this document, to the WHO recommendation of how to test, they suggested to test 2 targets, which was a tradition in case of coronaviruses. In MERS, it was the same. And you are familiar with the concept of CT, I assume. This is an amplification plot of real-time PCR. The cycle that this amplification plot crosses the threshold which is called CT, and it's very correlated with the concentration of the template in the sample. So if you prepare a serial dilution of the sample and then run the test, you usually expect to have a linear regression like this with an equation like this, a slope, and also an intercept like this. And this intercepts means that when you have only 10 to the 0, which means one template, so you get a CT of, for example, 40. This intercept is usually between 35 to 40. So beyond that, it is not really reliable. And you have a slope, and this is related to the efficiency, to how the kit is set up and how good it is. Anyway, there's another point with this virus, with coronavirus, interesting. Coronaviruses are RNA sense viruses. So the genome itself works like an mRNA. So if it goes inside the cell, it can start transcription. It can start translation of the proteins. And this is what happens in the first part of the genome. So ORF1A and 1B are the proteins in this region are expressed by the genomic RNA. But when these proteins are expressed, they start to produce subgenomic RNAs from the rest of the genome. And these are the structured proteins. And for example, you see N has a very small mRNA. But the important point is that you have this sequence of N both here, and so far and so forth. So you have several copies of mRNAs which contain the N sequence. But you have only one copy or a very few copy of the genome itself. You have many copies of eGen also. So this is some not maybe unique structure of this virus, which is important for us. So the problem was this. Based on the WHO guideline, we had to do 2 PCR tests to make sure that this is a positive test. And then we realized that we have some samples. For example, we do the test for eGen, and then the CT is 33.5, 33, for example, 0.8, and then RDRP is negative. In the beginning, we were confused. Should we report these samples as positive or negative? Then we did this analysis. We prepared a regression a diagram like this, a scatter plot, with the CTs of E gene and RDRP. And we noticed that they are strongly correlated with an R2 of almost 90%. So they were very well correlated. And the other point is that the average CT of RDRP was 4.5 higher than the average CT of E gene. So that sounds reasonable. That sounds logical because when the CT of E gene is something around 35, 34, if you add 4.5, it goes so high that it is undetectable by the test. So that's why they are negative. And then we tested these samples with another set of parameters with N gene, and they were positive. So we suggested that if we do the test only with E gene, that would be enough. We do not need to go for 2 genes. That was one evidence. The other one was here. You're familiar with the concept of sensitivity and specificity. You have some true positive, false positive, false positive, true negative, and false negative. And given the reported sensitivity and the specificity of PCR with the samples of nasopharyngeal, sensitivity was something like 75% and 98% specificity. So if you test 100 patients, you will get 75 positive and 25 negative. And if you test 100 normal people, healthy, you will get 98 positive, negative, and 2 positive. So this is right. But the important point is that in the field, this is not important. This doesn't matter. It is important for me as a medical doctor to know what I should do with the positive or negative tests. So the other important parameter is the positive predictive values and also negative predictive value. Okay, going back to the same table, if the prevalence of disease is something around 1 in 1,000, so for finding 100 patients, you have to screen something like 100,000 people. Roughly about 100,000 of them are normal, are not all healthy, and only 100 are patient. So if you do the math again, the positive predictive value, which means that the probability of being really infected when you have a positive test is 75 divided by 2075, which is something around 3.6%. So when the prevalence of a disease in a country or in the region is low, the PPV is low, regardless of high sensitivity and specificity of the test. But if you go to a high prevalence region, for example, 25%, then the figures are changed like this, and then the PPV is like 75 divided by 81, which is more than 92%. And that was the case when we started doing the test. The first group that we started to test were patients in the hospital, and especially patients in ICUs. And most of them were positive, so almost 1/3 of them were positive, or 1/4 of them at least. If you pick up a sample from just a random sample, 25% was the chance of being positive. So even one test would give a very high PPV. Based on these two sets of evidence, we convinced the National Committee of Coronavirus that we can do only one test, and that was really life-saving for us because the capacity of testing was very limited, and this released almost 25 to 30% of our capacity. So we could do more tests at that time. However, a few days later, after we did this, maybe 2 weeks later, WHO gave this suggestion that in areas where COVID-19 virus is widely spread, a simpler algorithm might be adopted, in which, for example, screening by RT-PCR of a single discriminatory target is considered sufficient. So what we found. And it is also suggested by the US CDC now. Anyway, this was the evidence that we produced, and based on this evidence, we convinced people that we should change our policy. However, right now, we prefer to go for 2 targets because we are moving to low prevalence setting, we are expanding the testing, and we are somehow afraid of a new mutation may happen in one locus, so we may miss. This is not probable, but it's possible. So we may miss some cases. So we prefer to use kits or tests with 2 targets in a multiplex format. Okay, so this is what we did with the molecular tests and expanded the network. A few more slides I have on serological tests. So, as usual, there are a set of antibodies which are raised against any pathogen which enters the body, and these antibodies different proteins of the virus, and proteins or these antibodies have different meaning. Usually, for example, you know that first in the course of infection, you have seroconversion in IgM, then IgG. We'll come to this point later. We will see how it is the case in the COVID-19. And then there are different modalities for testing, like ELISA, like chemiluminescence, and also rapid tests. So In April, this paper was published in Nature, and it was very interesting. The title is also very attractive. The researcher taking a gamble with antibody tests for coronaviruses. And that was true. That was what we believed, and that was what we found. So we have already evaluated at least three domestically made ELISA kits in the country. Another one will be evaluated tomorrow. And some kits have been imported from abroad. And in a few days, we will even go for the chemiluminescence by Roche to see how it works. So far, we have found that sensitivity is something around 80%. Although the companies claim that the sensitivity is much higher, more than 95, 97%, but we have not found it. So when we go, and specificity was high. In some cases, in some kits, it was around 90%. So even 90% is not suitable because we had a lot of false positive cases, especially for IgM. But now, just yesterday, we tested another kit, an Iranian-made kit, and it was almost 100 or 98% specific. So we had very, very few false positive. But the most important question here is not if we can detect the antibody or not, is why should we detect the antibody? So what is the meaning of having antibody or not having antibody? 280-something patients, and they had the data on seroconversion of 26 of them. And you see, in these patients, 7 of them had the IgM seroconversion before IgG. This is the normal, this is the usual scheme that we expect. 9 of them had synchronous seroconversion, but interestingly, 10 of these patients had IgG before IgM. So this is very confusing. And that's why we do not know what is the implication, what is the benefit of this test. Just to give you another example, sets of rapid tests are based on also detecting antibodies. So this is one example. This is for a patient who was the PCR positive at the day from the samples which were taken the day before doing this test. This is a very good kit, by the way. So you cannot see anything here, but if you study very carefully, there was a very weak IgM band. So it was good. In 1 week, he turned to this. So strong IgM and IgG, and PCR was negative. So he was IgM positive, which usually means that the patient is in acute phase. But this was negative. Another interesting patient was this. This was also, you see the pattern is like this, but at the same time, he was PCR positive. So he was infectious. So we do not know if we can rely on the results of such a test or not. And in our hand, sensitivity of these tests were not higher than 70%. It was even lower with some brands. In the hospitalized patient, it was something around 50% in outpatients. So we believe that it's not reliable, so we did not let importing of this, despite the high political and commercial pressure which were upon us in the beginning of the outbreak. But the specificity was rather good. So, and we do not know indication of this. So far, we usually use them just for epidemiological studies. And the WHO says that WHO does not recommend the use of antibody detecting rapid diagnostics. And I think the text itself was bold, so I did not make it bold. Use of detecting rapid diagnostic tests for patient care, but encourages the continuation of work to establish the usefulness in disease surveillance and epidemiologic research. And it was also similar to the US FDA. US FDA suggests that you can do the test, the serologic test, with writing this consideration in the brochure, which if you really pay attention to them, they say that this test is just useful. And okay, there are some molecular test, rapid tests, which are based on isothermal amplification. We are evaluating some of them. So I think I'm almost done, and maybe a little bit more time that I wanted to talk. But this is my last slide. And what are the future challenges? So the dimension of expanding such a system is highly related to the needs of the health system. we are not going to make more burden on us if they do not need it. We do not want to do more tests if there is no plan for positive or negative cases. So we try to help them to make their mind and they make a good decision. One problem that now we have faced is the returning to work criteria. We do not have really good criteria for that. We're working on them. And there are some pressure on us to do the scale of testing. Now we can do 20,000 tests per day. If we go, for example, for some other strategies like pooling, we may go to up to 45,000 tests per day. But we have not seen the reason so far. And this is very related to logistics. I believe that this is by far the biggest testing campaign in human history, because we have done more tests in case of, for example, HIV, but we have done so many tests in 40 years. Now we have done so many tests in only 4 months. And this is really big campaign, and the cost, the logistics, the human sources, resources, and all are very limited, so we cannot afford to expand it unlimitedly. Sample collection is a big challenge still, because nasopharyngeal swabs give up to 75% sensitivity, and oropharyngeal swabs up to 50%, which is not good. So there are suggestions for collecting saliva. We are also working on that. We hope this can help us a little bit. The other problem is that we need a very good web-based information system, a laboratory information system, manage so big amount of data that we are producing and we are collecting every day. So thank you for attention, and I would be pleased to answer to questions if you have any. Thank you. Is there any data related to antibody cross-reactivity between SARS-CoV-2 with other coronaviruses or other viruses? Usually this is the duty, or this is up to the producer to provide the evidence of this cross antibody testing. But because we are giving them the emergency use authorization, we in Iran are not very concerned with this, and just we want to see if there is any false positive in the samples collected before the outbreak, so maybe by mid 2019. And if that's okay, we accept it. But there are evidences, yes, definitely. And in some ELISA tests, we found that the sensitivity was, specificity was something like 92%. And when the prevalence is low, this leads to a large amount of false positive cases, which we believe must be due to cross-reactivity between other coronaviruses, infections in the past, and this coronavirus. Another experience is that, which is reported, is that the antibodies from a patient with a history of SARS infection in 2003 still can detect SARS-CoV-2. So the antibody is raised, and it can neutralize even the new virus. So it is possible, yes, and it is even probable. Okay, you're welcome. Okay. This is from Ardalan Mazohari. How about PCR detection in animals such as cats or dogs? Well, we have at least one experience with that. Some of our colleagues brought us a sample from a cat, and he didn't tell us that this is from cat. So we did the test, and we saw that the internal control is negative, so we repeated the test a few times. Then he told that that was not a human sample, and it was a cat, and it was positive. So yes, in my personal experience, it's possible. And I think just today, we are doing testing on some a series of animal samples. And you already know that there are several reports from cats and dogs who are infected with COVID. Okay, Nupur Gar question, what could be the approaches for increasing sensitivity? Sensitivity of what? of ELISA or PCR? Anyway, both of them, this is a long story. I think we do not have enough time here to talk about it. These are technical, technical challenges of developing kits. So there are a lot of ways. For PCR, for example, you may relax the thermal cycling. You may change the enzyme that you use. You may change the primers, the probes, the concentration of the primers and probe, their sequence, and so forth. And for ELISA, again, you can use different approaches. You can use direct or capture, for example, for higher specificity. And there are several ways to do that. Okay, someone is. Okay. Mohammed, since it is a respiratory virus, would you recommend IgA detection from nasal antibody detection for antibody detection? Okay. One important aspect of suggesting a test is feasibility. The biggest problem with this approach is how do you want to collect the samples from nasal swab? It's not easy. So usually they go for IgA in serum. And right now, the kit which is developed by Roche detects total antibody, which is IgA, IgM, and IgG. And they say that it's very sensitive, more than 97%, I think. But there was a report from UK that they did not get such a high sensitivity in the field, maybe something around 88%. But in serum, yes, this is a recommendation. But for nasal swab, I'm not sure that you can do that. سعادت خداوردیوا, you evaluated sensitivity in 70% of patients. What was the sensitivity? Pardon, I do not understand what you mean. Could you please, Saadat, repeat your question? Okay. And Mr. Nasab, how do you evaluate your laboratory network to know that it works well? Okay, there are different tools, there are different approaches. First of all, we give them, we hope that we have given them proper training for doing that, both before doing the test or within this outbreak. So that's one point. We give them good material. I explained to you the process that we grant them the permission to do the test. And then when they run the test, we follow the results. So when we see that in one area, the positivity rate is very high or very low, this is alarming. So we may go there, and right now, today, we have our colleagues are visiting one of these labs to see what's the problem. The other important approach is to prepare quality assurance or quality ECAPs, external quality assessment panels and programs. And we have done that. We have sent these panels to almost, I think, 50 labs by now. And when we receive the result, we check the result from different points of view. For example, if the CT of what they get is close to what we expected, how they interpreted the results, and so on. And we give them a mark, and then we ask them for corrective measures. And the last one is to going for site visits, and that's also in process right now. There's another ECAP program which is supported by WHO, and we probably will start it next month. Okay, you're welcome. Mr. Kavish, is it possible to design a rapid testing kit with an accuracy more than 90%? Well, I'm not sure. With serology tests, the problem is not that they cannot detect antibodies. The problem is that what is the meaning of this antibody? I'm not really optimistic for antibody rapid tests. But there are other molecular tests even, for example, based on LAMP, based on RIA, which give the results within, for example, half an hour. They're rapid, and they are useful for some indications. For serologic rapid tests, I'm not sure that we can reach 90%. Ardalan Mazari, rapid tests can be conducted for screening instead of PCR for parallel testing. Well, we do not recommend it, nor WHO does, because as I told you, we have people who are seropositive. We don't know if they are immune. Right now, have the infection. We have people who have acquired the disease, who have contracted the disease, but now are IgG and IgM negative. So, and especially within the first week of infection, almost all of tests, all serologic tests are negative. So, it is not advisable to use serological tests for screening. Mustafa, so usually how many genes do you check for PCR tests? How do you interpret the result? Right now, most of the kits that we use are for check at least two targets, N ORF1AB or EN ORF1AB or RDRP more specifically. And another gene for a housekeeping gene for as an internal control to make sure that there is no inhibitor in the process and the sample is properly collected from the patient. So right now we suggest this is our common practice right now, checking for two genes. Well, for how to interpret the results, some of these tests suggest to, if both are positive, so for sure it is positive. For sure, I hope for sure, because there's no certainty here. But if one is positive, one is negative, we look at the shape of the graph and CT of the graph. If one, for example, is E gene or N gene is around 35, then the ORF1AB is negative. We repeat the test. If we get the same result again with a good shape of curve in N or E gene, then we consider it positive. If it turns negative in the repetition, then it is negative. So it depends on the case by case. Again, Sadagat Asadova, we know that the infection cases decreased in Iran. How do you explain the recent increase in the number of the infected people? Okay, first of all, now the capacity of testing and the testing practice is much more popular here in Iran. Right now, we look for contacts. We do contact tracing for patients, and most of these patients are not, they are not ill. So we find them earlier. We give them advices, supportive treatment, and less and less need to be hospitalized now. So the mortality is decreasing. But you are right. We have a rise in the number of cases that we detect now. And to be honest, that also gives me an impression that maybe, I'm not sure that if we need to do so many tests or not. Dr. Sharmin, can you repeat the name of genes you suggested for testing? Based on the suggestion by Charity Berlin and WHO, usually E gene and RDRP. Based on the protocol developed in Hong Kong University and Pasteur Institute of Hong Kong, N gene and ORF1AB. Based on CDC, US CDC, they suggested only amplicons from N gene, at least 2 amplicons out of 3. So all of them are positive. There are also some kits which look for evidence of S gene and ORF1AB. Mustafa Nasal, what is the accuracy of both PCR-based and serology tests in your laboratory network? Well, I'm not sure about this question because there's no real gold standards. If we go, for example, for case definition, if we rely on the CT scans, maybe our sensitivity of our test is something around 50%. But I'm not sure if CT scan is a good indicator. So I would say I would stick to the definition of WHO, which says that a case is considered a positive case when the test is positive. I cannot give you an exact number for that. You're welcome, Dr. Sharmin. Okay. Okay, thank you very much for your active participation in this presentation. I hope you have enjoyed it, and I hope that I have given you convincing answer. Okay, one last question from Mohammed, I assume. Helmi Aziz. Does reinfection occurs also in Iran? We have follow-up cases who went positive to negative and positive again. Okay. We still are not sure if these are reinfection or just a fault in the test, because we have had cases who were positive for 45 days. And you know, by definition, again, by recommendation, when you want to consider someone negative after being infected, you need to have 2 consecutive negative PCR results. So they knew that maybe one of them would be positive and the negative, and then the second one would be positive. I'm not sure if these are cases of reinfection or just an extended infection, or the other point, the other aspect is that we're not sure if these positive patients with usually high CTs in a real-time PCR are really infectious or not, if they can transmit the disease or not. My personal feeling is that these are not cases of reinfection. Okay? Am I done? Okay. Okay. Thank you very much.